So we have a clip up next that's in the agenda, and it's from Dr. Nasha Winters, and she's going to be coming to us. She did a pre-recorded announcement for us. She wanted to be a part of our conference, but she couldn't be here. And so Nasha is going to be talking about testing, assessing, and addressing. And so we're going to run that clip now.
Hi, everybody. I am really sorry I can't be there with you in person, but trust me, I am there with you in spirit and all the amazing souls that are sharing their knowledge with you today and learning from each and every one of you. My name is Dr. Nasha Winters, and I'm kicking us off today to talk about this concept of test, assess, address, and the personalization of your journey. So what happens at every medical conference I attend, whether it's conventional, medical conferences, whether it's integrated medical conferences, whether it's patient-driven medical conferences, is that everyone gets seduced by the thing, right? The protocol, the new sexy tool, the new sexy device. And believe me, I do the same. So it's nothing to be ashamed of. It just is. It's our human nature. It's sort of our internal raven, if you will, of always seeking the new shiny objects. But at the same token, I want to help you understand that what these conferences are really about is more about sort of window shopping. It's not that you have to go and purchase every single thing you see, but it's that you're learning what's out there and available. And then with the right tools, which we're going to talk about today, you can determine if they are a fit for you, either a fit for you as a clinician bringing these types of tools into your practice, or a fit for you as a patient going through your own journey to see if some of these tools might be warranted in your own journey. Oops. All right, we'll get there. A couple of basic disclosures. You can read on more so we save our time together. Good old Eli Jones, an amazing oncologist over in the 1920s that really, this quote sits above my desk, by the way, which is that of do not get so taken up by the cancerous condition that you forget the most essential part of your treatment, the general condition. And this is where we want to start our conversation today, is that there is a danger in going blindly into following any protocols, either from standard of care alone or from alternative care alone, or even the blend of both of those, the integrative approach, without knowing your very specific, unique terrain. Okay, it's very important to know that. The illusion of a one-size-fits-all or a magical pill or a single target, single solution is really outdated. These generic protocols often fail the patient as well as the practitioner. And the consequences of moving blindly into any protocol can be, number one, dangerous. It can backfire, but it can also be a missed opportunity because we're now in the era of true personalized and precision medicine and true sort of patient data or patient biofeedback that allows us to really understand who we're dealing with at any given moment. And when we start to think about this, where do we want to begin? We want to begin by exploring the terrain of the individual, because this is what tells us the story. Here's an option for you. You can go into this hyperlink and do your own evaluation. This is our Terrain 10 questionnaire that helps you start to get a sense of where you are in the process. I encourage you clinicians to apply this as well, not just the patients, to understand kind of a few things about your own terrain. There's been this renewed interest in discussion about terrain. I've watched it early on in my practice, or early on in my medical school training as a naturopathic clinician. We talked about terrain a lot, but it kind of went by the wayside. It's sort of making a resurgence, and people are starting to talk about the terrain. You're seeing it as a buzzword. You're seeing it rising up in the SEOs on social media and Google searches. But basically, this is the concept of holistic health, recognizing the importance of a balanced internal environment and a robust immune system in both the prevention and treatment of disease. And then specifically with that, the terrain theory or the terrain approach itself focuses on strengthening the body's immune system and ecosystem while, kind of creating this really robust internal operating system while also directly addressing the issue at hand, combating the issue at hand. And so the goal of working with the terrain is about neutralizing potential harmful effects while potentizing resilient effects. No. So this is where we begin. I always have people saying to me, and likely you said this yourself, or other clinicians in this room have heard this as well, I was healthy until I got cancer. I don't understand why I got cancer. I do all the things. I walk 5 miles every day. I eat a vegetarian diet. I, avoid the blue lights. I mean, all the different things we can say that we do, right? These are the folks who are always shocked. Oftentimes, my health warriors, my yoga therapists, my Pilates instructors, my nutritionists, my nurses, my doctors who themselves find themselves in the quandary of dealing with a cancerous process, they kind of scratch their head and wonder, well, gosh, I did all the things, but you didn't. It's impossible to do all the things living on planet Earth today in these modern times that since the World War II, we have 100,000 new chemicals in our environment. And we've not even talked about how those interact with one another, much less stand alone. So what I've highlighted here on this slide for you are the ones in orange are the ones that you are literally exposed to every single day, whether you willingly know it or not. Many of us are exposed to all of these things every single day, maybe willingly or unwillingly so. And so when you look at this, these are outlined by IARC, which is a third-party non-biased research agency in the oncology space. And what you see on this slide are things that are considered known carcinogens. And these bright orange ones, so light pollution, artificial flavoring and coloring, sodium benzoate, which is one of the sort of preservatives, pesticides, including glyphosate, ultraviolet rays, and it's actually not so much the ultraviolet rays that are a problem, but what they're interacting with inside of you. Exhaust, engine exhaust, air pollution, these are known carcinogens. So that's where when folks think I'm doing everything right, but hey, maybe you're going for that 5K run along a busy road, or maybe you're doing all the right diet and lifestyle, but you're sitting up in front of your computer screens at 2 a.m. doing doomsday scrolling. Or maybe that beautiful coconut milk that you're drinking every day is loaded with carrageenan as a stabilizing agent. Or perhaps you're trying to stick with a more of a vegetarian or a plant-based diet, but you're eating foods that are more closely related to factory than an actual farm. Just examples of things that you are being exposed to on a regular basis, things that our grandparents and our great-grandparents never came in contact with. My teachers in environmental medicine, Dr. Walter Crinnion and Dr. Joe Pizzorno, wrote an amazing clinical textbook about environmental medicine and its impact on disease in general, and specifically entire sections in that textbook on cancer. This is a really powerful textbook on clinical environmental medicine, something if you want to dig deeper to dig into this. But these things are real, and they're things that we do not talk about and that industry makes sure that we do not talk about without then classifying us as orthorexics. So if we're questioning what goes into or onto our food, we're considered mentally ill, right? Or if we are someone who is questioning the narrative of our farming practices or our food resources, we are considered conspiracy theorists or outright loons. So that's just something to consider. The other thing I want you to consider just at the very biochemical fundamental level here is this idea that at the source of this, and we're going to talk about this further in a moment, is our mitochondria. These are the little organelles within each of our cells that are the receivers of all this information, right, that we're looking at on this slide, all the information that we're giving them. And these high lipid content mitochondrial membranes accumulate many lipophilic or fat-loving toxins such as polycyclic aromatic hydrocarbons, alkylating agents such as our chemotherapies, metals such as lead, cadmium, which can be found in a lot of our favorite chocolate, mercury, which is from our coal burning plants, xenobiotics, arsenic from our rice and chicken resources, xenobiotics, mycotoxins, just to name a few. These little mitochondria are also very susceptible to pollution because of the presence of cytochrome P450 enzyme pathways in our liver that help to detoxify these accumulated chemicals. And if our phase 1 or phase 2 are not working properly, for instance, if our phase 2 isn't working, but our phase 1 is, we can actually make the toxins we're exposed to even more toxic. And so now that you have knowing this of things that you might be getting exposed to that you're not aware of, be aware that the damage that these create to your mitochondria can in fact impact your overall longevity, your ability to protect your genome, your ability to actually have resilience and resistance to all chronic illness, including cancer, and even your ability to induce cell-programmed death, known as apoptosis, which is under direct guidance and direct dictate of our mitochondrial function. And when we take this a little bit further, we live on a planet where we are currently all overfed and yet undernourished. You're going to see here in a moment the most common nutrient deficiencies that we're all walking around with today, but we're living far from our natural genetic origins. Our cells literally cannot keep up or adapt to these changes in what is considered a very short period of time. We literally live or die by our screens. They dictate everything in our lives. We are more connected now than ever via social media, but also more alone than ever. The scientists call this the era of depression and the era of despair. And it's also why in the United States, we have the lowest level of longevity in the world, and it's getting worse year by year, thanks to the era of despair, where we are using outside sources such as opiates to numb the pain or suicide to completely bypass the pain altogether. We have normalized factory created foods. We have normalized the increase of carbohydrates and sugar and alcohol and caffeine in our lives, which is what we socialize around, what we celebrate around, and what we think is just normal. If you question that narrative, you are considered abnormal. In fact, those of us who do question it can often even be demonized, and we can be thrown under the bus when we're actually just trying to be the messenger. You know how that works out, the messenger often gets attacked. We will self-medicate with things like carbohydrates, sugar, alcohol to make up for the lack of sweetness in our lives. We no longer cook. We celebrate stress and busyness. We can no longer hide from the endocrine disrupting chemicals like plastics and glyphosate that are just insidious in the world around us, in the air, the soil, and the water. And the way we start to understand how much may be lurking under the surface, right? What you see when you look at me or somebody else is just literally the tip of the iceberg, but there's a heck of a lot happening inside. None of us know the real story, the real biography that any of us are carrying day by day. What you see is what you see, right? But we need to dig deeper. And the methodology of test and assess and address is the critical path forward to guide you, the patient, or you, the practitioner, through the cancer wilderness. And our questionnaire, the way we start with this is in the exact why of someone's process. What led to this moment that they're meeting a diagnosis of cancer or working with you as a clinician? So when someone thinks that they've done all the things and yet they're still getting cancer, or they're still progressing, or they eventually succumb to the disease itself, we will often jump to our own conclusions. Our own story, our own narrative, our own situation might be clouding the reality, when we could actually be asking different questions and learn from these situations rather than making assumptions. And so the future is now, which is this personalized, data-driven approach that is the foundation of long-term survivorship. Each of us is unique. Our genetics, our lifestyle, our environment, even the way in which we see and interact with the world. The data illuminates the path forward. And an empowered patient is a patient that achieves better outcomes. And that means the clinician achieves better outcomes as well. And where do we begin? We first begin by exploring that terrain by looking inside of our proverbial mitochondrial bucket. This link up here, this hyperlink, shows you the day-to-day assaults on your mitochondria, of which we have an average of 60,000 assaults a day to our mitochondria. And when they're in good number and efficiency and effectiveness, they can handle it. But things happen, things accumulate over time that the burden gets heavier and heavier, the bucket gets fuller and fuller. So things like our epigenetics, our metabolic, what we're fueling ourselves with, our environmental exposures, our microbiome, our inflammatory process, our immune system, our oxygenation and cell proliferation, cell growth, vascularization, our hormonal milieu, our stress and circadian rhythm processes, as well as our mental emotional. These are the main drops in that mitochondrial bucket. As I said before, the mitochondria are these amazing receivers of information, taking in everything you're exposed to in, on, and around you. That includes substances, that includes light, that includes water, soil, air, food, but it also includes thoughts and people. We are an expression of the 5 closest people around us. And so if you're constantly around toxic people, you too will experience and express that toxicity. And so looking at the role by doing that Terrain 10 questionnaire and starting to evaluate further and really understanding the person's biography to understand their biology, we start to really listen. We start to really understand who this person is before us, and we start to understand the role that the person plays in their own disease creation or health creation, and we understand the best path forward to help them have better outcomes. And where we can start is using data, not dogma, using truth and using path forward methods versus guessing games. We've come to a time in our medical prowess that no one has to go through this blindly. But one thing I want you to remember is none of us should ever strive for average, okay? We all want to be outliers. We all want to not be the statistic. Lab values, you guys, are based on the average of the population in the region in which they're being tested. So pathological ranges are used to diagnose disease, and yet we're missing an opportunity to see things smoldering well before they're a building engulfed in flames. And outliers, is who each and every one of you should strive to be. You don't want to be average. You need to keep thriving, not just surviving. And a functional or optimal range versus an average range is actually what's going to be preventative, as well as help create resilience, and as well as give you tools to actually combat whatever process you are going through. And so as clinicians, we will even start with your demographics. You'd be shocked at how much information we can get from someone's demographics. A name tells us a lot, a gender, an age, it tells us about where they are in their life cycle, their marital or their relational status, the number of children they have, and their current living situation, their occupation, their height and weight. Their zip code can tell us oodles amount of the things they're getting exposed to, and not just their current zip code, but the zip codes they lived in at various life cycles, as well as their current diagnosis, the date of that original diagnosis, and subsequent treatments that they've done leading up to the moment that they're sitting in front of you. This information is like, as a clinician, we become a detective, okay? We start to understand so much. We can already start to make assumptions that we can then follow up with further testing, further evaluation. So for instance, I have patients in the North Carolina area in a place known as Lake Norman, a highly, highly affluent part of southeast part of the United States. But it also is a very hot spot for very weird, rare cancers in the pediatric population, thyroid cancers, really wonky neuroendocrine tumors. It's known for that. There's hot spots of cancer all over the United States, throughout places like Houston, around all the gas and oil, all along the Ohio River Valley and the Mississippi River Delta. These are the places that also have the highest levels of cancer, and yet no one is asking those questions. So your zip code tells me a heck of a lot. If I see someone telling me they grew up in the Great Lakes area, I pretty much assume that they've got some persistent perchlorate in their bodies, right? It's like kind of insidious in the water and soil in these parts of the world. Where I lived in the beautiful, pristine Durango, Colorado, for many, many moons, one of the highest levels of arsenic in the soil and water in the world, not just in the United States, and also the highest levels of mercury because of all the coal burning plants around. We had a huge hotspot of funky cancers, a ton of thyroid disorders. So that tells me a lot. Your socioeconomic status tells me a lot. Your educational status, your marital status, your child status. These are the questions I start to ask. Your age tells me where you are in the life cycle. There are certain times, certain markers along the path that have what we know as like flares, if you will. We know that we have a rapid aging, for instance, around the age of 44 and around the age of 56. These are things that have been very well elucidated. These also happen to be high moments of cancer diagnoses. They correlate because aging is really a result of our mitochondria. So our longevity is based in the health and wealth of our mitochondria. And so there's these big shifts that happen in our physiology just chronologically that are very, very interesting to consider. I mentioned earlier that drugs can play a role and nutrient deficiencies can play a role. And the nutrients that we as patients dealing with a cancer diagnosis or really any chronic illness are most often deficient in are these: magnesium, B12, zinc, vitamins A, D, and K, selenium. Okay, these are big, 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 big players. And these are the most efficient. These are also the players that are protective to the genome, that help you methylate, that help you detoxify, that help you with tissue repair and immune function. They are critical players. And yet I don't think I can even think of a single patient I've worked with cancer that had all of these in optimal working order. So a lot of the medications we use just in standard of care medicine, or even a lot of the medications we used in oncology, directly further inhibit these nutrients. The very nutrients that are required for you to utilize any of your therapies better and to have a better prognosis. And so these are some things that you would want to consider. Okay, further, there's also a really great hyperlink down here that you can go into the drug-induced nutrient, drug and nutrient interactions of the most common used medications and get deeper into the weeds with this if you want to learn more. The other thing we do is we've got I think it's like almost 12 pages now, our observational nutritional physical exam. We take patients through a journey that they can do this online, they can do this with an advocate, they can do this, with their clinician to start to evaluate their nutritional status, not by running more labs, because that's helpful, but your body will tell the story. So for instance, everyone take a look at your fingernails. Now, if they're covered with paint, we're not going to get much information. But if you see white spots, that's a classic zinc deficiency. If you have issues with anxiety, insomnia, constipation, that's a classic magnesium deficiency. If you get cold sores or cracks along the sides of your mouth, that's or kind of burning tongue, especially red tip tongue, that's a B12 deficiency. If you get bumps on the back of your arms or blur or kind of night vision or floaters, that's a classic vitamin A deficiency. These are just some really good examples. If you have a difficulty smelling, zinc deficiency. So these are just some of the examples of things that we look at in a nutritional physical exam. We used to be able to even just do a reflex hammer on your Achilles heel to know your thyroid status, or use a pupillary dilation test with light flashing into your pupils to see how your adrenals were functioning, or even have you take a blood pressure sitting or lying down and then immediately moving to a standing position, take your blood pressure again to see if you have a very big pulse pressure difference, which can also shows hypotensive or hypertensive or adrenal dysfunction as well. There's so much that we can learn about just absolute visualization of the body. It's astonishing to me how far we've gotten from that. And it's increasingly difficult to do this with telemed, but we've created these checkoff lists that we can go through with the patient to learn more about their nutritional status, which is going to be what gives you your resilience to any chronic illness. And then these labs, these are just examples of the labs I've had my patients run every single year for decades. When I had a private practice, I can't even think until we get down to probably the OAT, the single nucleotide polymorphisms. Most of these above were the standard annual labs that we ran on every single patient, okay? And the ranges that you see here are based on the functional ranges or the optimal ranges or the ranges that I've concluded through my 30 plus years in the field that are most telling of health creation and disease prevention or treatment. The other things here, such as urinary and blood or breath ketone levels, continuous glucose monitors, macronutrient counters, nutritional physical exams we just talked about, heart rate variability, GKIs, those are some of the newer testing that we can look at with folks. The OAT testing, the buccal swabs, the tigloglycine, the 8-OH-DG, and the anti-mitochondrial antigen, these are specific tests that can actually establish the health and wealth of your mitochondria. Single nucleotide polymorphisms today can be tested in direct-to-consumer testing, such as Nutrition Genome or 3x4 or others on the market, which we're going to talk about further in a moment. Today, given the fact that over 93% of us are considered metabolically broken, most of us, in fact, upwards of 70% of the population, is walking around with a body fat composition higher than 25%. So basically, their hip to waist ratio is off. And then we talk about these questionnaires. We can talk about your Terrain 10. We can talk about your adverse childhood events score. We can talk about signs and symptoms. We can look at personal and family medical history. There's so many ways to tell a story about a person's terrain. And probably the most telling for me throughout my practice and what my patients have kind of given the name for the trifecta, the almighty trifecta, these three tests together, the lactase dehydrogenase, the high sensitivity C-reactive protein, and the sedimentation rate tell a tale. These are the hyperlinks here that I've given you so that you can go into the deep dive about what each of these mean, what each of these establish, because any one of them on their own are prognostic in a cancer diagnosis and a cancer response to therapy. But collectively, there's a few studies here that talk about this. Together, I have found personally that these three as a collective are far more telling than any tumor marker and any imaging done. So let me give you an example. If I have a patient who comes to me and they're perfect on their tumor markers and their imaging shows no evidence of disease and they're ringing the bell because they've just completed treatment and they're super excited, but then I get their labs and I see that all three of their trifecta are off, I'm nervous because I know it's a matter of time, days, weeks, months, rarely longer than months, that cancer is back, expressing with a vengeance. It's not gone when you see an elevated trifecta. The opposite is true, is if I have someone who's got some questionable things happening on their imaging, elevations of their tumor markers, but their trifecta is perfecta, that tells me that patient is still in the driver's seat, not the cancer. And that despite them having cancer, they are managing it like any other chronic illness. And so it's very important to stabilize these three tests. This is very, very important. And then don't ever underestimate the power of a good old CBC. This is typically run routinely on every single cancer patient, not because of the way I use it, but because they run this test to see if you have white blood cells high enough to get your next dose of chemotherapy or your next dose of targeted therapy or your next radiation treatment. And yet, if you want to dive deep into a 90-minute lecture I give breaking down the CBC, that's how much time it took to really show you how this is an incredibly powerful, inexpensive tool that you can run on your own if no one else is willing to run it for you for less than $10, a pop. This is one of the most prognostic ways to understand how you're doing. The CBC with differential is incredible. The white blood cells, for instance, if they're chronically low during treatment, standard of care wants to give you things like Neupogen and Elasta to get it falsely raised enough to legally feel comfortable to give you another dose of chemo. And yet it's not a true boost of your white blood cells. It's a massive inflammatory process they're creating with those medications to then bring in an extremely oxidative inflammatory medication that if you're lucky and you have enough mitochondrial function, you can quench those reactive oxygen species and respond okay. But if your body has been through the ringer for a while, that just adds insult to injury. So white blood cells being low throughout often just tells us you need to take a little break. You need to spread out your treatments. You need to help quench that oxidative stress before you add more insult to injury. Things like rising platelets. Rising platelets are a clue that you have a coagulation problem, that you might be having a clot risk lurking under the hood. You might have a viral process happening. But it also, platelets rising can also be prognostic and showing cancer progression. Rising monocytes are the same thing. That shows something known as the macrophage shift from a phase 1 to a 2 to 1 or 1 to 2, depending whether they're rising or lowering. That is also a moment when you start to see the monocytes rise, you start to recognize that the cancer is now cloaking itself from the immune system, and it's increasingly harder to find those cancer cells, target them, and kill them. A neutrophil to lymphocyte ratio is actually known as a prognostic indicator of overall survival across the board. All of these things, by the way, are filled up in the references section, so you can go down all the rabbit holes you want to read these PubMed studies to show that these aren't opinion, these aren't naturopathics, wonky ideas about how to read a lab. This is what I've learned from books such as, I want to make sure I'm looking at my notes for this, because I've spent 33 years studying the likes of Datis Karazian, Dickon Weatherby, Wallach's, kind of general diagnostics. There's so many amazing lectures I've learned. People like Wayne Sedano, Michael Wald. These are some of the areas that I've studied in person in training, in reading, and following, plus 30 years and millions of metrics later have elucidated a lot of patterns, which are also well clarified, classified, and articulated in PubMed studies. So the things I'm describing here, you could simply take any one of these and just Google in a PubMed or search in a PubMed, HCT, which is hematocrit and prognosis in cancer, or poor neutrophil to lymphocyte ratio and prognosis in cancer, or rising platelets and prognosis in cancer. And suddenly you start to realize we are missing an opportunity by digging deeper to even know if the very therapies we're taking, be it standard of care or alternative care, are helping or hindering the process. And then what we have our clients do is we have them create these spreadsheets so they can see the trajectory, so they can see the patterns, because a single point in time means very little. You have to have comparisons to understand the story, right? So if you just have one day where suddenly you have a high CRP, but everything else is okay, well, that could be that you stubbed your toe that morning, or if just your LDH is high that day, maybe you had a really heavy workout, or maybe just your ESR is continuously high, and maybe that's just showing you've got some autoimmune issues, or maybe your white blood cells just tanked, but on the way to the ER or on the way to get your labs run, you were almost in a car accident, which created a major cortisol rush. These are examples of how labs need to be looked at over time and in comparison to be able to understand and elucidate the patterns. The other thing that's really hot topic these days is immune therapies, when, where, why, how to use them. In 2018, MD Anderson came out with something known as the prognostic score, which is a scoring system to see those folks who would have a better or a worse response to immune therapies. So basically, if you had 3 or more of the risk factors, you were less and less likely to have a good response with immune therapies. Weird that they created this scoring system and yet never used it. But I realized when that came out that I've been using this prognostic scoring system in my own process for decades. And I have kind of my own revised version that I have here. So if a person of a certain age, if they're needing some support to do their day-to-day function, if their lactate dehydrogenase is elevated in above my functional ranges, if their platelets are either too high or too low, if their neutrophils and their lymphocytes are a 2 to 1 ratio or worse or flipped, there's a problem. If there's any happening autoimmunity, there's an issue. Anything going on with the liver metastasis, liver, fatty liver, hepatitis, any of those things, that's an issue. And so these are the types of things that we started to look at, and we started to recognize maybe these patients shouldn't rush into an immune therapy. Maybe we should prepare them for it in a more thoughtful way. This includes in considering how assertive or aggressive you want to be with therapies such as mistletoe or Coley's toxin, or even dendritic vaccines, or any of these other therapies that you might be hearing about over this week together. And then SNPs. Talked about these earlier, the single nucleotide polymorphisms. These are our blueprint, you guys. This is what we are born with, but it's what we have impact over, that we have autonomy over. We can change their expression on a regular basis. I want to get to my notes to make sure I hit some of my highlights given this short period of time. And so let's talk about the basic categories that you're looking at here. There's the drug response. category. There's the high penetrance, meaning the high sort of familial or genetic gene risk. There's the nutrient deficiency vulnerabilities, and there's the optimization, dietary optimization. So for instance, SNPs like BRCA1 and 2, TP53, SIRT1, MLH1, MSH2, GATA3, MDN2, these are all considered high penetrance genes that can increase your risk of cancer, helping you know ahead of time to be more on target of digging under the hood, of looking at your terrain, exploring it so you can shore up and be more resilient to these types of diseases. SNPs along the CYP pathways, CYP1B1, 1A1, your 3A4, your CYP2R1. These I don't have as much listed here, but these are your drug response. These are your CYP450 enzyme pathways, showing how well you metabolize certain drugs, both conventional and off-label, and even certain nutrients and nutraceuticals. It can determine how fast or slow you metabolize those things. So for instance, an issue with your CYP2D6 affects your response to things like antidepressants, painkillers, chemotherapy, tamoxifen. Those are just examples. So knowing this up front, we then know, for instance, if you've got a CYP2D6 and you're looking to take tamoxifen, maybe you should look at indoxifen, which is a version that's already more processed and broken down and metabolized further downstream, that you, with some CYP2D6 issues, would do better taking versus the standard tamoxifen. About 70% of the population have a hiccup there. So why is that not looked at in a simple blood test right from the get-go to help you determine the better drug? Nutrient deficiencies, so things like MTHFR, that's going to show us folate and B12 metabolism. VDR or CYP2R1, these are going to show you issues with vitamin D synthesis. Your ACATs, your FADS1s and 2s, these are showing how you digest your fats. Your TCF7L2, these are things that show you your high propensity towards diabetes, but also someone that doesn't tolerate carbohydrates. These are folks that basically are destined for diabetes if they eat too many carbohydrates. These are the types of things we can help people know what diet is the best for them, when, where, and why. And then the era of liquid and tissue biopsies, you guys, it is incredible. These are the ways that we can use non-invasive methods in the liquid biopsy, or more invasive methods if you're already getting a biopsy or a surgery, to take advantage of that tissue to get more information, to know precisely what you're dealing with, to know the personality of the tumor as it interfaces with the personality of the terrain and of the personality of the person, to help augment and choose strategies that are most beneficial to the patient. And so when we weave this all together, this metabolic approach that's looking under the hood at all of the things from their SNPs to their blood biopsies, to their lab tests, to their questionnaires, to what they're putting in, on, and around them. This simply test and assess process really elucidates a sure path forward. That pattern recognition and that hand-on evaluation helps with clinical decision-making and patient empowerment. And so things like this, you're going to hear from Dr. Winkler this weekend. I actually want to thank him for the inspiration behind this slide, is that there's this idea, this is kind of an old school, a resurrection of an old school idea that he and I learned from a chiropractor many, many, many moons ago, is when to push and when to pull back. Don't let the aerobic, dysaerobic conversation confuse you, because this isn't about an Otto Warburg effect. This is kind of old languaging around this, but basically, if someone's trifecta is perfecta and their inflammatory markers are not too high and they're not too oxidized, you can push a bit harder. But once they've reached that place where everything is on fire, you have to be very careful, because not only if you push too hard, you will push them off the cliff. This is where so many succumb to the treatment of cancer, not the cancer itself. So this was just an example of one way as clinicians, I train them to think about this, of when to push and when to pull back. And it's all of that testing we just went through that helps determine, including these little day of moments, doing a scratch test, looking at urine specific gravity, looking at how urinary and salivary pH align with one another to help us determine where the patient is in that moment when they come into your office. So then you know how best to address them. Maybe that day isn't a day to do UVBI and a high dose IV vitamin C. Maybe you're going to do more of a quenching like a poly MVA or a curcumin IV, or maybe some DCA nebulized instead. Maybe that isn't a day to do the chemotherapy. Maybe that's the day to take a little pause, take a little chemo break. Maybe it isn't the day to rush into radiation. Maybe it's a day to take a break and maybe up your melatonin levels. Things like that is how we as clinicians think about it. But with all the sexy tools and all the sexy treatments and the price point that goes with those, if we do not address the fundamentals, we fail our patients and we fail ourselves. And so you have to determine the essentials of their health. How are they resting? What is their circadian biology? What is their diet? What is their community support? My version of the CDC is looking at the circadian rhythm, the diet, and the community. And in the context of these essential determinants, do they know when the moon rises? Do they know what the cycle of the moon is in? Do they watch a sunrise or set? Do they get out in nature more than 15 minutes a day? Do they know how they're digesting? Have they done a bowel transit time test by looking at how fast they're moving things through to understand how long they're holding onto their nutrients or dumping them? Do they know the source of their water? Are they getting access to clean air? You know, like right now, I worry so much about folks like my sister-in-law who lost her home in the Altadena fire, and so many others living in Southern California right now that probably won't have clean air for the next 2 years. And the amount of known carcinogens that's in circulation, the amount of known carcinogens that are in wood smoke by itself, much less the tens of thousands of homes and built businesses and vehicles that burn down, we will see, as we have in other big fire histories, a huge surge in cancer diagnoses. I'm also very happy that someone will be talking about the COVID impact. I think Dr. Winkler will be speaking about that because in our hundreds of clinicians in 43 countries, we've been collecting our own data to tell you that the spike protein is absolutely part of this essential determinant, and we need to be doing a lot more as clinicians to help clear that spike protein, even in those who never had the vaccine and even in those who never had the infection. So the future of healthcare is now. We don't want to rush into protocols. I know it's going to be tempting this weekend of all the things you learned to rush home and do it all. Don't. Pause. Learn. Truly know who and where you are. Only then can you chart the path and choose the right tools to take you where you want to go. And healing begins with understanding your terrain. And finally, using the test, assess, address methodology, be an outlier. Use the tools that are available to you today from the wonders of standard of care. Come through a different lens. Look at the prognostic indicators to help determine your success or failure of any given treatment. It's never one and done, and it's never one thing, and it's never one approach. It's never one target and one treatment. And what worked for me may not work for you, and what worked for you may not work for another. There's ways to learn more, whether you are a clinician or a patient who wants to apply this in your own lives or your own practices. There's different ways that you can access this. I've loaded you up with references because this is what I do. If you want to dig deeper into the metabolic approach to cancer, the book on mistletoe, or have some interesting conversations with folks in the Metabolic Matters podcast to learn from some of the best minds in the field, please have a listen and follow. If you want to get further training done, you're welcome. And following us on social, you can see what we're up to and see what we're sharing amidst all of this. But finally, what I want to say is what's happening here with the Annie Appleseed Project, with the beloved presenters and the beloved participants, is that we are a small group of committed people, committed to changing our own lives, which in turn changes the world. And so with that, I'm very grateful for your time and attention, and I send you all many healing blessings and an amazing conference.